My name is Crystal Vaughn. I'm a second-year PhD student at Memorial University Faculty of Nursing. And I'm working on building and refining my project proposal entitled The Status and Evolution of Virtual Nursing Practice, a multiple comparative case study in primary care. So this will be a general overview of my project, my plans that I hope to begin this summer. And so I hope that this gives you a general overview of some of the upcoming work that's being done in Canada and directly related to virtual nursing practice here in Newfoundland and Labrador. So while this is very much an introductory period into this type of work, it should develop a very promising program of research for myself and hopefully lots of new things to come in this area. So first, I would like to respectively acknowledge the territory in which I study and reside on the island of Newfoundland as the ancestral homelands of the Beothuk and the Mi'kmaq. I would also like to recognize the Inuit of Nunatsiavut and Nunatukavut and the Innu of Nitassinan as their ancestors as the original people of Labrador. So for this presentation, first I'll outline my research question and the various components of my doctoral project. Then I'll review the preliminary findings of phase 1, which is underway and almost complete, that being the scoping review. And then I will go through my proposed research plan for phase 2, the multiple case study, and then review nursing implications for my research and strengths and limitations of this study. So first, I just want to provide a couple definitions and make sure that we're clear with those as we move throughout the presentation. So there's been many definitions used to describe virtual care, and oftentimes they've been used synonymously, although there are often many differences with these terms, such as telehealth, virtual care, digital health. So the definition that I use is from Jamieson et al. From the Women's College Hospital Institute for Health System Solutions and Virtual Care in Toronto, where they define virtual care as any interaction between patients and or members of their circle of care occurring remotely using any forms of communication or information technologies with the aim of facilitating or maximizing the quality of effectiveness of patient care. So what I've gathered from many of my readings that virtual care is often used as more as a modern term that encompasses all forms of information technology in healthcare delivery, both synchronous and asynchronous, so such as telephone, video, and text messaging. And then as well, primary care. So I want to ensure that this is understood throughout. So primary care refers to the initial point of contact patients have with the healthcare system to address their healthcare needs and is delivered in a variety of settings, such as clinics, general practitioner offices, and health centers. And this differs from primary health care, which is an approach to care that encompasses the equitable distribution of comprehensive healthcare to meet the needs of individuals along the health continuum. So we probably all either directly or indirectly notice the impact the COVID-19 pandemic has had on the use of virtual care, both across Canada and worldwide. So particularly telephone-based healthcare has become more widespread and was a relied upon resource to sustain healthcare delivery during peak outbreak periods in the pandemic. For example, prior to the pandemic in Ontario, less than 2% of primary care visits were carried out virtually, but we saw this increase to over 70% during the early periods of the pandemic. And this has been notably sustained into 2022, where it was reported through the Canada Health Infoway that 33% of the visits in this survey were carried out virtually from January 2021 to March 2022. So through both the technological advancements and the use of virtual care that we saw catalyzed during the pandemic, it's with no surprise that the health systems at a provincial, territorial, and national level have a mutual goal to enhance the availability and quality of virtual care being delivered. For example, here in Newfoundland and Labrador, the Medical Association developed a virtual care strategy in 2019, and the Health Accord has highlighted strategies to integrate digital technology into our healthcare reform efforts. And strides have been made by NELCHI to enhance the collection of virtual care data, which has been previously presented by Ashley Dinn. So as we discuss virtual care specifically within a primary care context, we should consider the transformation of primary care that has occurred worldwide and how Canada has been quite stagnant in the area compared to other high-income countries. So funds have been provided at a national, provincial, and territorial level to improve primary care processes, including the development of collaborative teams to enhance primary care delivery. But little progress has been made in many provinces and territories. If we consider the ongoing primary care reform that is needed in many areas, we should look at what the goals of these reform efforts are. And that is to improve access to care, continuity of care for patients, and promote cost savings for health systems. And what's interesting here is that virtual care has the potential to produce these same outcomes and therefore should be considered a valuable asset in primary care reform. So as I mentioned, team-based care has been the focus of primary care for the benefits it provides in coordination of care, integration of providers in a healthcare environment, and the quality of care that can be provided to patients. So within these teams, nurses have contributed significantly as the provider who has the largest workforce presence across health systems. So if we bring both of those pieces together, primary care nursing and virtual care, we know based on recent reviews completed by Dr. Luca J. Al that nurses in primary care have contributed to the effectiveness of team-based care if we look at both patient and system outcomes. We know based on recent national survey from Canada Health Infoway that the proportion of nurses delivering virtual care has increased from 20% in 2017 to 51% in 2020. And a recent analysis of this survey identified that nurses working in community care, which encompasses primary care practices, are more likely to deliver virtual care services, emphasizing the importance virtual nursing practice has in primary care. So despite the increased presence and importance of nursing and virtual care throughout primary care, many role descriptions at this point do not explain how nurses in primary care contribute specifically to virtual care delivery. So to address this, my overarching research question for my project is, how do primary care nurses contribute to the delivery of virtual care, and what has influenced the enactment of their roles? So I'll describe this in two phases. So the first phase, which is underway, has an overall aim to identify and synthesize the international literature surrounding nurse contributions to virtual models of care within primary care settings. And to achieve this, we're completing a scoping review, and the protocol for this review was published in BMJ Open in September of 2022. And the analysis phase is underway for this, so I'll present some preliminary findings shortly. And then for the second phase of this project, we aim to explore virtual nursing practice within team-based primary care in Canada through stakeholder perspectives using a multiple comparative case study approach. And the protocol for this study is being developed, anticipated submission either this month or early May. So we'll look closely at these two phases, but I'm going to go through the guiding frameworks that are used for this project. So the two frameworks I'll use to inform and guide my research are the nursing role effectiveness model and the nursing care organization framework. So the nursing role effectiveness model is a structure process outcome model underpinned by the Domobedian model for quality of care. So this model shows the interplay between healthcare structures. So you see here, patient, nurse, and organizational factors, as well as process being nurse roles described as independent, medical care related, or dependent and interdependent, and outcomes of care delivered by nurses, so nursing sensitive patient outcomes. So these roles here in the middle could all be used to describe roles of primary care nurses in virtual care, despite the team-based interdependent nature of primary care. So for this project, we're interested strictly in the structure and process components of this model and not the outcomes piece at this time. So I'll present an adapted model after I show the next framework. So the nursing care organization framework as well has been used. So this framework outlines dimensions in the organization of healthcare services that can influence the delivery of patient care by nurses. So you see here staffing, scope of practice, and work environment. Within the work environment dimension there, you see capacity for innovation and practice environment. So this framework identifies the resources and processes to consider when assessing the integration and optimization of nurses, while also recognizing the relationship between these dimensions. And the work environment dimension here captures virtual care well through the capacity for innovation subdimension, whereby nurse roles and overall potential within a virtual care context can be situated. So although the nursing care organization framework aims to consider key dimensions that influence nurse health and job satisfaction and patient care quality and safety, again, we'll not be considering these dimensions in the study as we're not going to look at outcomes. So when these models are combined, you'll see here the structure and process components were kept from the nursing role effectiveness model. And we expanded the structure component to include the 3 key dimensions from the nursing care organization framework. So we have the work environment dimension within the nursing care organization framework, as I mentioned, includes practice environment and capacity for innovation. So we'll still consider these, but we've kind of encompassed them in the work environment component for simplicity in this adapted figure. And similarly, the nurse element within the first model that I presented resembles the scope of practice dimension in the second framework. So both consider the education and experience of the nurse. Therefore, in this adapted model, the scope of practice concept accounts for that nurse component in the first model. So the interplay between the 3 components of the second framework are noted here without a direct relationship with the patient characteristics concept. And the process component is unchanged as we're still looking at roles across these 3 different levels. So if we begin looking at phase 1, the scoping and review, we'll first look at the overall objectives for this. So we look to describe the attributes of virtual models of care within primary care settings that involve nurses and outline the nursing roles that are carried out through virtual care or virtual delivery in comparison to in-person within these settings, and then identify barriers and facilitators to the implementation of virtual models of care within primary care settings. And so to do this, we carried out the review using JBI methodology that the MUN Faculty of Nursing is affiliated with JBI. So we used that methodology to guide this review, and Covidence software was used for the screening process. Studies were collected from multiple databases, including CINO, Medline, Embase, and APA PsycInfo. And based on the JBI methodology, the eligibility criteria for this review was based on the population concept context framework. So I'll go through this next when I explain kind of what we included and what we excluded in this review. All right. So first, the population of interest for this review are nurses practicing in primary care across any professional designations. We included research that pertained to nurse practitioners, registered nurses, as well as licensed practical nurses, also referred to as registered practical nurses in Ontario. And we included studies that did not specify nurse designation as well, as we were interested in getting an overall picture of virtual nursing practice and primary care. So if they didn't specify the designation, we just acknowledged that. We recognize that nurses practicing in primary care may carry an additional titles specific to this practice area, such as general practice nurse, and internationally these titles differ. I did a document analysis a couple years ago that identified the titles across countries in primary care, and they differ quite significantly. Here in Canada, we use primary care nurse or family practice nurse, but they're not protected titles, so they're kind of used more informally. And we are interested in strictly in nurses who are licensed or practicing, and we excluded studies that focused on student nurses. So for the concepts component, we're interested in nursing roles in the provision or coordination of services in primary care settings using virtual models of care. So studies should involve nursing action and interdisciplinary collaboration, meaning that actions may involve interventions that are independent, dependent, or interdependent in alignment with our model. And this labeling of roles may vary across nurse designations. For example, a role that may be independent for nurse practitioners may be an interdependent role for registered nurses. Roles being discussed should be delivered by nurses in primary care and not by specialist nurses, such as those with specialty training. So like a foot care nurse or diabetes nurse. So those with additional training, if that was indicated in the literature, then we did not include that. We wanted to keep it very focused on primary care nurses as they enter this field, whereby there is no mandatory education required to practice in this area. So we excluded studies that provided unclear description of nurse contributions to virtual care delivery, whereby they referred to roles of healthcare providers collectively. So they may have had physicians, pharmacists, nurses all included in the study, and it was unclear exactly what nurses were doing. And studies that involve the use of digital healthcare without patient-provider interaction. So those that may have been looking at strictly at EMRs or simulation for clinical-based learning or training. So those were excluded as well. And for the context component, we were interested in studies that were situated in the context of course, virtual care and primary care. With the presence of that patient-provider interaction. So we're aware that, kind of as I mentioned earlier, virtual care may be referred using other terms such as telehealth, remote healthcare, digital health, as well. Similarly, primary care may be referred using different terms across jurisdictions. So family practice, general practice, primary healthcare. So each of these terms were captured in our search strategy. And we included international literature that was not limited by country or date of publication, and both English and French literature. And we excluded studies that were situated in another area of community health nursing. So primary care is kind of a sub area within the umbrella of community health nursing. So those studies that related to home care, public health, they were also excluded. So for some of the preliminary findings from this review, so the total sources that we found were set 1,715. After title abstract screening, we had 364. And after full text screening, we included 21 sources from the scholarly literature. And most sources were excluded for being carried out in the wrong setting, while it was not true to primary care. So we were unable to identify whether it was more of an overarching community health thing or if it just wasn't specific that it was primary care based on our definition, then we weren't able to include it. If it had the wrong design, so we excluded text and opinion pieces and protocols. So oftentimes those designs were found and then we weren't able to include them. Where the nurse required specialty education, as I mentioned, to carry out their role. So that was often found and we excluded those, and lack of clarity surrounding roles. So I also mentioned that as well. If roles are grouped together with other providers and it wasn't clear exactly what the nurse's role was, then we weren't able to include that. So in addition to the 21 sources found from the scholarly literature, we also identified 7 additional sources from the gray literature after website searches of relevant web pages and Google searches. So from these 28 sources, 11 of them were from the United Kingdom, 6 from Canada, 4 from the US, and 2 from Australia. Other countries that had a source included were from Korea, Netherlands, New Zealand, Spain, and Sweden. So of the sources that were included, 12 involved registered nurses, 6 related to nurse practitioners, 2 related to licensed practical nurses, and both of those were here in Canada. And if the nurse designation was not specified, as I said, we still included it, and that was 9 sources in total. So based on these role categories, which have been identified from the University of British Columbia, where they have a web page that you can go to, and it outlines virtual roles for clinical areas for nurses to carry out roles specifically in primary care. So those categories were used to kind of group the roles that were identified from each source. So 79% of the sources, or 22 sources, did identify nurse roles that related to care coordination. And all of these were interdependent roles. So they relied on another provider. So it may have involved the arrangement of follow-up care that involved another provider, arranging diagnostic testing that may have involved another provider. And then secondly, chronic disease management and triage and assessment were also identified, 39% and 21% of the studies. So for chronic disease management, that may have involved telemonitoring. So if an individual had remote patient monitoring, which we see here in Newfoundland, if they had that at their home and that was being monitored by the nurse at the health center, then that was included in chronic disease management. And for triage and assessment, it was pretty self-explanatory. It just normally involved the triage of an individual calling in, and then they would decide on the level of care that was required. So the roles within these categories will be broken down a little bit more than this in the overall findings, but this is just the initial stages of it there now. All right, so next we'll go into phase 2, so the multiple case studies. So for this study, which this is the portion that relates specifically to Newfoundland and Labrador. So the objectives of this case study are to understand the roles of registered nurses and nurse practitioners in virtual care delivery within primary care teams across Newfoundland and Labrador and Nova Scotia. So I'll kind of get into that a little bit later as to why there's only the 2 jurisdictions and why Nova Scotia. We'll also describe the barriers and facilitators to integrating registered nurses and nurse practitioners more widely in virtual care within primary care teams across Newfoundland, Labrador, and Nova Scotia, and explore how COVID-19 has influenced the roles of RNs and NPs in virtual care within primary care teams in these provinces. So to do this, case study methodology is often used when an in-depth understanding of a certain phenomena is the desired outcome. So this study design is concerned with description and acquiring knowledge to inform practice, policy, and research, which is key to what we're doing here, as this is more of introductory work in this area, as I mentioned. So I've provided the overall aim here at the top, so we can recall this while we discuss the case study more in depth. So for this multiple case study, referred to as multiple because we are including more than one case, and I am also referring to it as comparative, as we have 2 jurisdictions that we're looking at, and essentially we'll be making comparisons across those. So for this case study, we'll use Merriam's case study approach, which there are various case study approaches to use based on the data that you'll be collecting. To gain insight and discover and interpret new findings through qualitative research methods, including qualitative interviews and document analyses. So within this case study, we'll explore and compare multiple cases, characterizing this design, as I said, as a multiple comparative case study. So Merriam specifically defines a case as a thing, a single entity, a unit around which there are boundaries. So this is quite broad, but emphasizes the importance of boundaries to delimit a case. So I'll go through that as I kind of define the case shortly. So we'll be looking specifically at qualitative data, and we will carry out simultaneous collection and analysis. For Merriam's approach, the literature review is a key component to designing the case study, which is true based on our reference to the scoping review throughout these case study methods. And Merriam's approach provides clear direction for each stage of the research process, including conceptualization, collection, and analysis. So it's very helpful as kind of a novice researcher myself. So now we'll look at how we'll define the case in this study. So more broadly, we'll look at the unit of analysis, which Merriam describes as being equal to a case prior to fencing in the case with its boundaries. So for the study, the unit of analysis is the primary care practice model of interest, which is collaborative care clinics. We'll use the term collaborative care clinics at this stage. Unclear if I'm going to change it, but we recognize that there are various terms that could be used to describe this interprofessional collaboration in primary care clinics. Newfoundland just recently outlined kind of a new term that they'll be using, I believe, is family care teams. So these terms do differ across jurisdictions and even within jurisdictions. So this might change, but this is what we're referring to right now, which just mainly describes interprofessional collaboration of various disciplines within a primary care setting. And next, we're looking at a specific phenomena of interest, which for this study is described as the enactment of nursing roles. So we're looking specifically at nurses and their practice as they carry out a variety of roles. Then we're interested in looking at the contextual description of the phenomenon to allow knowledge to be unique and embedded in experience. So much like our contextual interest in the scoping review, we're interested in the enactment of nursing roles in virtual care and primary care settings. And we further define each case or collaborative care clinic by their boundaries. So this is kind of how you fence in the case, as I mentioned. So for this study, we'll include or we'll kind of bound them by their geographical area or province and community type. So whether they're located in a rural or urban area, we'll be including both, but we'll be bounding the case by this criteria. So as our cases are collaborative care clinics and we understand the two boundaries that have been set for these cases, we've outlined clear inclusion and exclusion criteria to help recruit for each case, where we'll be recruiting at the case level, meaning that we'll recruit clinics rather than individuals. So I'll just briefly outline the inclusion and exclusion criteria. So we'll be looking for collaborative care clinics where primary care services are provided by at least a registered nurse practitioner, and physician, with or without other providers. And virtual care should be used for the delivery of primary care services. The physician and the nurse should be co-located in the same clinic. So the nurse shouldn't be in the clinic and the physician in another area, although we realize that may come up. So that will be kind of assessed on an individual basis as we move through, because we know in rural areas, sometimes nurses are in smaller centers and the physician is more in a tertiary center, and that collaboration still occurs. We'll be including all regions and zones in Newfoundland and Labrador and Nova Scotia, but we'll be excluding remote coastal areas of Labrador. So this is just because there is not really a direct comparison for this in Nova Scotia. So unfortunately, you just aren't able to make that comparison. You know, it's a unique model of care that's used in these areas. So at this stage, those will be excluded. And of course, nurses should be involved in virtual care delivery. So Before we begin discussing recruitment, I just want to make sure that we're clear with how these boundaries help define our cases. So we have 4 cases, so 2 in Newfoundland and Labrador and 2 in Nova Scotia, 1 representing an urban area and 1 a rural area in each province. So although the topic of this project could provide significance and be relevant to all provinces and territories, Newfoundland is my province of study, of course, where relevant networks are accessible. And Nova Scotia is another Atlantic Canadian province with socioeconomic and socio-demographic characteristics that are similar to those across health regions in Newfoundland and Labrador. So it allows for that comparison. And when we're looking at rural areas, we should make sure that that is well defined. So using a Statistics Canada definition from 2001, this has been used throughout various other rural nursing research. So rural communities refer to populations living in towns and municipalities outside the commuting zone of larger urban centers, whereby urban centers include communities with populations of 10,000 or more. So for recruitment of these cases, we'll perform web page searches to identify collaborative care clinics that may meet our eligibility criteria, in which case we'll contact the administrators or direct contacts to share study details. We'll also send digital posters with study details out through the professional networks of our study team to recruit clinics. And we'll use social media to recruit using digital posters, again, making it clear that we're recruiting at the case level. And so some of these organizations that we may seek to do this through: the Newfoundland and Labrador College of Family Physicians and the Family Practice Nurses Association of Nova Scotia. So within each clinic, we'll select participants from the following groups. So nurses, physicians, and administrators. And then external to the clinics will also be including policymakers and nurse regulators to situate findings within a larger provincial primary care nursing context. So to satisfy the nursing perspective, we'll include nurse practitioners and registered nurses in primary care. Licensed practical nurses will not be included in this portion of the overall project, just due to their limited scope of practice, and more specifically so within virtual care. Next, although team-based care environments are optimal and ideal in primary care, they've not been realized in many provinces. So nurses in primary care often practice independently if they have an autonomous practice, so like nurse practitioners. Or in collaboration with a single provider. So in this case, more so in collaboration with physicians. So to remain consistent across cases, team member perspectives will be collected from physicians who practice alongside nurses in their collaborative care clinics. And we will include administrators from these clinics as well, who are responsible for organizational processes and have a role in the supervision of nurses. So participants in this group may include nurse or clinic managers, clinic executive directors, or others. So physicians may be the administrators as well. If they are, then they would satisfy both categories in a way. Clinics included in our study will be asked to identify policymakers and nurse regulators who, or representatives from nurse regulators who are knowledgeable in virtual nursing practice and primary care. Policymakers may include, but are not limited to, provincial program managers and government officers within virtual care and or primary care nursing with knowledge in this area. So policymakers will provide insight on existing or developing policies or programs that may have relevance for primary care nurses delivering virtual care. And regulators will include representatives from our provincial regulatory bodies, so such as the College of Registered Nurses of Newfoundland and Labrador, and in Nova Scotia, the Nova Scotia College of Nursing. So in each province, a single regulatory body is responsible for the professional regulation of both nurse practitioners and registered nurses. So we'll be seeking individuals with expertise and involvement in practice and policy, and ideally with insights on both urban and rural nursing in primary care. And nurse regulators specifically will provide insight on planned or executed initiatives to guide virtual nursing practice in collaborative care clinics through more of a professional practice lens. So overall, our priority is to ensure all perspectives are well represented by the participants included in each case. So we'll aim for a total sample size of, I've adjusted it since this slide. So 20 to 24 participants. I don't anticipate it going up to 28, although it could, which would be approximately 5 to 6 per case. So the sample size within each case may fluctuate. So as I said, physicians may take on dual roles. So physicians may be administrators in the clinic as well. And physicians also, it's likely that they'll work alongside both the registered nurse and nurse practitioner if they all work in the clinic together. However, if they only work alongside one of the nursing designations, then we may need 2 physicians in each case, one that works alongside an RN and one that works alongside an NP. So there's a breakdown here. So we expect at least 4 registered nurses and 4 NPs, and at least 2 physicians, possibly 4 in total, administrators, likely 2 to 4, and the policymakers and regulators, we may only province, but we may have 1 for each case, so 2+ for each of those. So the final number will be determined as we move through the study, but the most important thing is to ensure that all perspectives from these 5 groups are represented in each case. And participants may also recommend other nurses or providers in the clinic that may provide valuable insight. For example, if it's more of a well-rounded clinic and has other providers in there, such as social workers or physiotherapists, they may also be good team members to interview. So those individuals as well may come into play, depending on what the clinic is like. So for data collection, we'll first carry out qualitative interviews with the participants that I identified, remotely via Zoom or telephone. These interviews will be recorded and transcribed. We'll have participants self-report their demographic characteristics. So these may include their license designation, their level of education, their position and title, as well as their years of experience. And the interview guide for these interviews will be informed by both of the models I identified earlier, the frameworks, as well as the scope and review findings. So these will guide the interviews for each participant group. So this table outlines the concepts that we'll focus on for each participant group. So it aligns with the figure that I presented earlier. So the structure here has the 4 components, and then the process has the 3 kind of categories for the roles. So organizational characteristics will be discussed by all participants. So organizational characteristics meaning those that are mentioned here. But only select participants will be asked to discuss patient characteristics. So nurses and physicians, as you'll see here, are asked to discuss patient characteristics. Policymakers and regulators, and potentially administrators who do not deliver direct care will not be asked to reflect upon characteristics of patient populations being cared for. And similarly, policymakers will not be expected to discuss nurse roles, as you'll see here, or scopes of practice, as they're not directly involved in the provision or coordination of patient care. And this highlights the variation that may be needed in the interviews. So we may need 3 to 4 interview guides. So these guides will include open-ended questions and probes to explore how primary care nurses practice virtually, including questions such as what activities or programs do nurses deliver virtually, what patient populations are receiving these services, what team members do nurses collaborate with in these activities and programs, what virtual delivery methods do nurses use, what resources are used to guide virtual nursing practice, and what has changed in virtual nursing practice since the COVID-19 pandemic. Next, although referred to as documents, this is essentially any relevant data that is not collected through interviews. So within each clinic or case, we'll ask participants who are interviewed to identify documents that are used to guide and inform roles related to virtual nursing practice and primary care. So these documents will be identified directly from participants, so we'll not seek further verification on the relevancy of the documents shared. This will be decided on by the research team. These documents may be publicly available or internally housed and not widely distributed or shared. And we'll ask participants to provide these documents throughout the duration of the study. So even after their interview, if additional documents come up, then we'll provide our information for them to pass those along. So we'll include policies, protocols, reports that may or may not be nursing specific. So for example, documents may be specific to virtual care delivery and primary care, but may not have nursing specific content. So these documents will be included if they're identified as guiding resources in practice, indicating applicability to nursing practice. So they may identify a limitation in the nursing specific guidance that's available for nurses delivering virtual care. As well, documents may have cross-provincial relevance, so they may be national sources. Other kind of more informal documents may include meeting minutes, guiding scripts, consent forms. And so, of course, through these documents, we want to gain a better understanding of what resources primary care nurses use to inform their roles in virtual nursing practice. And then lastly, for the data analysis, so the analytic techniques that we'll use for the study will be guided by Merriam's qualitative approach and informed by Greenheim and Ludman's content analysis to make within and cross case comparisons. So make those comparisons both within provinces and then across jurisdictions as well. Analysis and collection will occur simultaneously. Two researchers will independently code the interviews and documents for more abstract codes to develop a coding template. And then we'll use NVivo software to organize these transcripts and codes based on the themes and categories that we identify. And once all perspectives are obtained from all participant groups and analysis is complete, we'll seek to ensure variation of findings and that all themes or categories are well supported by the data or consistently interpreted by the two researchers involved. So finally, ethics approval will be sought from the health research ethics boards, so in Newfoundland and in Nova Scotia as well. And we'll seek approval from the research proposals approval committee across regional health authorities if necessary. As well, written informed consent will be obtained from all participants prior to their involvement in the interview. So I want to outline some nursing implications for this work. So of course, in the development of this study, we've considered the nurse implications, and we anticipate that findings can build on existing policy. So such as the virtual nursing practice guidelines that have been developed by the College of Registered Nurses of Newfoundland and Labrador. And we hope that this will support and integrate their role more so in team-based care. Similarly, we hope to identify learning needs and professional development opportunities for primary care nurses to enhance their knowledge and skill in virtual care delivery. And from a research point of view, as I mentioned, this is a relatively new area of research that hasn't been well explored up to this point. So I hope that this can be a strong starting point that will allow this program of research to evolve and really support nurses in virtual care. And some strengths and limitations of this study. I think I have my order, yeah. As I mentioned earlier, we did exclude remote communities on the coast of Labrador. So of course I recognize this as a limitation, but I also know the difference in kind of how care is delivered in these areas, and this kind of would benefit from its own study and its own analysis. So I definitely hope to do that in the future. This study, as I also said, would likely could be carried out across Canada, and therefore the choice to include only 2 provinces is for feasibility purposes. But this limits the transferability of findings to other provinces and territories in Canada. For example, in Ontario, where primary care nursing might be even further advanced than Nova Scotia, and definitely more so than Newfoundland and Labrador, it may not be as applicable. There are no tools or frameworks that exist to guide the study. Therefore, a comprehensive approach is needed to guide the adaptation of existing frameworks for this area of research. Patients have not been included as participants at this stage, so I do identify that as a limitation. However, I feel that this is, as I said, some great introductory work that would allow us to identify patients that might be targeted for future research surrounding virtual nursing practice. As well, one of my colleagues who's also completing her PhD is doing some work on patient experience with nurses in virtual care. And that's based in New Brunswick and Quebec. So that will be interesting to kind of thread into this work. And the final point is probably a strength and limitation, as this body of knowledge has not been widely explored. So an increased amount of time and resources is needed to build the foundations for this area of research. So this is a limitation, as the areas to be explored are reduced at this point, as we carry out this introductory work to describe this practice area and understands more specifically how nurses contribute to this area of practice. But exciting for me because there's lots of kind of avenues that I can take and areas that I can go with this research as I move forward as an investigator. So that is all for me. So I would like to acknowledge Dr. Julia Lukwich, who is my supervisor, and Maria Matthews and Lindsay Hedden as well, my committee members, two of my patient partners, Tony Lehman and Joni Cranston, and members of our scoping review team. So Dr. Mary-F. Poitras, Dr. Shabnam Ashgari, Michelle Swab, and Dana Ryan. That is all.